Hi everyone, my name is Danielle Gatti Palumbo. I'm a clinical pharmacist and a RhAPP faculty member as well as a RhAPP board member, and today we're going over some journal clubs. The journal we have here is the effectiveness of methotrexate and leflunomide as corticoid-sparing drugs in patients with polymyalgia rheumatica that was published in Rheumatology Advances in Practice. So a little background on PMR is that glucocorticoids are basically our mainstay of treatment, and the EULAR and ACR guidelines both recommend methotrexate in patients that are at high risk of relapse and or prolonged use of steroids that may be at higher risk of steroid side effects, and these would include patients with comorbid conditions such as diabetes. They have not really recommended methotrexate more strongly, and that's due to the lack of evidence as well as controlled trials and contradictory results. The reduction in steroid side effects has not really been seen strongly with methotrexate in clinical trials. We've already examined the risk factors that put patients at higher risk of relapse as well as prolonged steroid use, and those would benefit from a steroid-sparing agent. And those risk factors would include females having an ESR of greater than 40 as well as peripheral inflammatory arthritis. So the aim of this study was to assess the effectiveness and safety of methotrexate or leflunomide in PMR patients in Argentina. This was a multicenter observational study of reviewing medical records in PMR patients from 23 public and private outpatient rheumatology units in Argentina from 2007 to 2023, having at least a 3-month follow-up. They excluded patients with GCA and included patients with PMR and arthritis that did not meet the criteria for RA and were also immunosuppressive naive. The results were expressed as medians and interquartile ranges for continuous variables and percentage for categorical ones. The two separate groups were compared using a chi-squared test for categorical variables, a Mann-Whitney U test for continuous variables, log-rank test for time to event data, and then a p-value of 0.05 was identified for statistical significance. Out of 186 patients that were included in this trial, 79% were female with a median age of 72, which basically is our PMR patient population. 77% of them were on methotrexate at a dose of 10 to 15 milligrams weekly, and 23% were on leflunomide 20 milligrams daily. Flare-ups were defined as both relapses as well as recurrences, and this occurred in 7% of the patients, and that was comparable between both groups. In those that were unable to stop steroids, despite being on methotrexate or leflunomide, they found no difference in the steroid dose between the two groups, meaning that no group required a higher dose of steroids. And 78% continued on their methotrexate or leflunomide regimen with no difference in discontinuation rates. So basically, there was no tolerability issues in both groups. What was different was the steroid withdrawal, which was achieved in 46%, and that was more frequently seen in leflunomide, and that was actually statistically significant. And also the time until steroid discontinuation was found to be shorter in leflunomide at 4.7 months versus 31.8 months in methotrexate, and that was actually statistically significant as well. And remission was found to be more frequently achieved in leflunomide, and there was a higher probability of achieving remission in the leflunomide group that persisted actually in a subgroup analysis of up to 40 months. So in conclusion from this article, they found that leflunomide was effective and also superior in achieving remission versus methotrexate as a steroid-sparing agent in PMR patients. Obviously, further data is required and research is required, but this allows for more options in our patients as well as patients that may not be able to take methotrexate, or also they need a shorter time to remission and also shorten the exposure to steroids. Some last-minute limitations to the study was that it was a chart review, so there was some data that was missing, so there may be some chart or information bias. There was also the dose of methotrexate was kind of on the lower end at 10 to 15 milligrams. And if we did push that dose up to 20 milligrams, we wonder if we could have maybe achieved remission a little bit more in the methotrexate group, and also a lack of follow-up with the leflunomide group. So I hope this summary of this journal was very helpful for you. For more information, you can visit us at rhap.org.